Hello, everyone. Good evening, and welcome to this session of Recall with me, Dr. Vyshnavi, and I hope all of you are doing well. First of all, I would like to congratulate all of you for having attempted the INI-CET examination. I know it's not an easy one. I know it has taken a lot of toll on your physical, mental health. I know that you have had a tough day today, and it's been a tough journey so far. So I will not really discuss too much into each of these topics that we're discussing today, or the questions that we're discussing today, but we will keep it only to the point that you're scoring from ENT perspective. Is it good or bad, or how much have you done from the ENT point of view, so that you're able to get a score for yourself in ENT questions. Also, for those students who would come back to this PPT or this presentation at a later point of time, would have a quick reference of all the INI-CET questions so that they know what to focus on for their upcoming exams. So first of all, good evening everyone, and let me know how was your exam today. I'm sure that the journey was not so easy, but I want to know the journey in the exam. How was it? Let me know in the chat box. Kaushal, you think you've lost all the hopes after this exam? Don't think that way. I think even if you've done bad, it's always the feeling that we have. It's never the truth. The truth will only come out on the day of result. So until then, be optimistic. Don't think negative about yourself. I'm sure that every one of us, when we've done something in the life, we always feel that, okay, we didn't do that well as expected. That's a common tendency. That's a common feeling that each one of us have. But don't give up at this point of time. Wait till the results. We never know what has happened. Okay, so medium, some of you are saying good, some of you are saying okay, fine. So most of you are saying tough, some of you are saying easy, fine. So let it be. Whatever it is has happened, has happened. Let's leave it there. Let's not break our head too much into what has happened. Let's just begin with the session. So before we go into the questions, this is a quick disclaimer that this is only recall based. We really don't know what was the language of the question, what were the exact options. But if you all guys will help me recall during this entire session, maybe I shall be able to give you better questions on the app when we upload it as the final PPT or the final questions. So we'll begin, and if there is any controversy in the question, or if you feel the options were not the same, or if the language of the question was different, please feel free to mention that in the chat box, because that really helps us to get very close to the question and to help other students who are preparing for the next exam. So I think this was an easy question. Which fracture is shown in the diagram below? So they've given you a diagram and they've asked you the fracture. I think this is very, very simple question, and we always do CSF, rhinorrhea and maxillofacial fractures as a mandatory topic in all our preparation, whether it is when we're doing full videos or RR videos or we're doing LRR. Everywhere we've discussed this innumerable number of times. So I'm sure that you already know this. So can you all tell me what is the answer for this? Yes. So if you can see here, the fracture line is running vertical. So when the fracture line is running vertical, what is the name of that fracture? We call this as Chevalier fracture. And what's the clue to this? We know that the name that contains a vertical line, L, that contains a vertical line, is your Chevalier's fracture. It is a class 1 nasal fracture also, and the fracture line is vertical. This happens when the direction of injury is from below. So what is the direction of injury? So if the direction of injury is from below. Jarjavet's fracture, on the other hand, would be a horizontal fracture. It is a class 2 fracture. What is Leafort's fracture? Leafort's fracture is a maxillary fracture where we have Leafort 1, which is horizontal, Leafort 2, which is pyramidal, and Leafort 3, which is a craniofacial disjunction. So Leaforts are your maxillary fracture. So I think this was very simple. The answer is Chevalier's fracture, which is class 1 fracture where the fracture line is running vertical. Let's start with the second question. What is the interpretation of the following? What is the interpretation of the following PTA conducted on a patient? So you have a Purton audiogram given. So can I know what is your answer in the chat box? Yes, I'm waiting for your answers. Is this a mixed hearing loss? Is this sensory neural hearing loss? Is this conductive hearing loss? Or this is an auditory neuropathy spectrum disorder? Okay. So we'll first start by doing the audiogram. What does greater than indicate? Does it indicate AC curve or BC curve? First of all that. So this greater than is a symbol for your BC curve of which ear? Of your left ear. We know it's left ear because the audiogram color coding is given in blue, which means that it's left ear. Greater than is a symbol that we use for bone conduction. What is X then? X is for air conduction of your left ear. Now let us see where is your bone conduction at 125 hertz. It's at 30 decibel. But where is your AC at the same time at 125 decibel? It is at 60. So what is there here? Do we have a gap of 30 decibel between AC and BC at 125 hertz frequency? Yes, so we have AC and BC. There is a gap of more than 20 decibels. The BC curve is also not lying in the normal range. It is below 20. So the BC curve is not normal. BC is also abnormal, AC is also abnormal, and there is an airborne gap. Now let us see at the second frequency, which is 250 hertz. 250 hertz, where is your BC lying? At 40 decibels. Where is your AC lying? At 60 decibels. So what is the gap here? Here it is 20 decibels, which is acceptable. So as we keep going, we see that the audiogram has areas where the gap is more than 30 decibels. So you see here the gap is about 40 dB, here it is about 20 dB, and here it is about 30 dB. So whenever AC and BC both are abnormal, we know that it is an SNHL, right? AC and BC abnormal, it is an SNHL. But the AB gap should be less than 20 decibels. So if the AB gap is less than 20 decibel, then only it qualifies into SNHL. But if the AB gap is more than 20 decibel, then what is it? It is mixed hearing loss. Okay, so in mixed hearing loss, AC and BC both are affected and the airborne gap is more than 20 dB, indicating that it's a mixed hearing loss, and that is exactly what we are seeing in this audiogram, where the BC curve is abnormal, AC curve is abnormal, AB gap is more than 20 decibel, then your answer is going to be mixed hearing loss. What is the difference between SNHL and mixed hearing loss? AC and BC both are abnormal, but the gap is less than 20, then only it will be SNHL. Now what happens in conductive hearing loss? In conductive hearing loss, the BC curve would be in the normal range. So BC would have been between 0 to 20. So in conductive hearing loss, BC will be in the normal range, AC will be in the abnormal range, and there will be an airborne gap. But we are not seeing that BC is in the normal range, BC is in the abnormal range, which is why this is not a conductive hearing loss and it is not an auditory neuropathy spectrum disorder, because in auditory neuropathy spectrum disorder, which is a retrocochlear type of sensory neural hearing loss, you get a pattern which is similar to your SNHL, not a mixed hearing loss. So the answer is mixed hearing loss. So I hope all of you got it. Yes, all of you got this? Quickly give me a thumbs up if you all got this. Quickly tell me, all of you got it or no? Yes. Let's go to the next question. Carhart's notch is seen in which disease? I think this is very, very simple. So let us see what is the answer. All of you know this. I'm not going to discuss. This is a repeat, standard repeat, which we see multiple times. Where do we get Carhart's notch? Yes, everyone's absolutely right, answering it right. That is Carhart's notch is seen in otosclerosis. It's a dip in the BC curve at 2000 hertz seen in patients who have otosclerosis. So that's the answer. We're not going into discussion because that's a standard repeat. Now the next question is, which treatment is shown in the following diagram? So they've given you a diagram and they're asking you which treatment is being shown over here. So you can see here, this is the malleus, this is the incus, but do you see, is there stapes here? Do you see is that stapes, or do you see there is a prosthesis that is connecting your incus? They have written here some bone is also removed. You see that there is a bone removed and you're inserting the piston through the oval window. Can you tell me what is this? Yes, so when they have removed the entire stapes and they have replaced it with an artificial piston, then we call it as stapedectomy. So the procedure that is shown to you is stapedectomy. Now, stepidotomy also, somebody is saying maybe that they have shown you the foot plate is present and through the foot plate they have inserted, then also it is stepidotomy. So I'm not sure. Some students said that foot plate was not there, some said foot plate was there, but whatsoever, the answer will be stapes surgery. Ossiculoplasty will be use of a TORP or a PORP, like a total ossicular replacement prosthesis or a partial ossicular replacement prosthesis, or use of a cartilage like your tragal cartilage or your conchal cartilage to replace or to bridge the gap between the ossicles. So here we are not actually doing, wherever there's an ossicular discontinuity, like between the incus and the head of stapes, there we bridge a small piece of, graft. That is ossiculoplasty. That is not the kind of surgery that they have shown you in this image. Myringoplasty is repair of the tympanic membrane, where they'll show you that grafting is being done under or over the tympanic membrane. So that's also not the image. Tympanoplasty is an operation where we repair the tympanic membrane and also repair the defect that is there in the middle ear. So not just ossicles, but also repair of the tympanic membrane. We have 6 types. I know all of you know it, so I'm not going to go into details of it. So that is not the answer here. Let's go to the next question. Most common test used in screening for neonatal hearing loss. Can you tell me which is the commonest test? Okay, Lamani, I think we will take it as stepidotomy. If that was the option, we'll take it as stepidotomy, no problem. Still, that will be the right answer. Yes, so whenever they're asking you a screening test, we know very commonly that otoacoustic emission is the screening test. The confirmatory test that we do for identifying hearing loss in neonates will be BERA. So BERA is the confirmatory test, whereas for screening, it is going to be otoacoustic emissions. The next question, which of the following conditions shows maximum amount of hearing loss? Can you tell me what is the answer? This is a little tricky question amongst the questions that have come so far. Okay, Khushi, you're saying in the previous question, Bera was not there, but clap and smile. Okay, clap and smile these are basically, these are pre-field audiometric tests that we do, but these do not have a relevance when it comes to, when we talk about screening. For screening, it is otoacoustic emission only. Okay. The next question, which of the following conditions show a maximum hearing loss? In serous otitis media, partial fixation of the stapes, foot plate, ossicular disruption with intact tympanic membrane, ossicular disruption with perforated tympanic membrane. So you have to answer which one will show you maximum hearing loss. Yes, Lokesh, Chaudhary Banwari. Yes, Nikita, Stork, all of you are absolutely right. The answer is ossicular discontinuity with intact tympanic membrane. Now let us see how. Whenever there is a serous otitis media, glue ear, non-suppurative otitis media, the amount of hearing loss that the effusion will cause is variable. Like if there is less effusion, if there is more effusion, if there is thick fluid, if there is thin fluid, there will be different amounts of hearing loss. But the maximum you can expect is not more than 40 decibels. This is the amount of hearing loss you could expect whenever there is a fluid in the middle ear. Now, when there is partial fixation of the foot plate of stapes, you can again expect the hearing loss somewhere to be between 30 to 50 decibel. This is max. 50 is like very much. But if there is complete fixation, then the answer will be 60 decibels. So when maximum amount of hearing loss that could occur if the stapes fixation is complete, like all over the stapes is fixed, then it is 60. Otherwise, it will be somewhere between 30 to 50. Now the question is intact TM versus perforated TM with ossicular discontinuity. Now let's see why is the answer intact tympanic membrane. So if I take this as our tympanic membrane and this is our ossicles, malleus, incus and your stapes, right? Now assume that there is a discontinuity between the malleus and incus. Now when a sound comes and hits the tympanic membrane, it will go through the malleus, but can it go beyond this to the incus? No, it cannot go because there is no continuity, there is a discontinuity, and because of this discontinuity, the amount of hearing loss that you can expect will be again between 50 to 60 decibels. But if there is a perforation of the tympanic membrane with ossicular discontinuity, meaning the ossicles are discontinuous as before, but now there is a perforation. So when sound waves come, of course they cannot go through the ossicles, but through the perforation they will go and hit the oval window. Some will go and hit the round window also, but now because there is an alternate pathway for sound waves to go to the oval window, the amount of hearing loss will be not as much. The hearing loss will be somewhere between 30 to 45 decibels. So the answer will be ossicular discontinuity with intact tympanic membrane can cause maximum up to 45 to 55 decibels of hearing loss. So this will be your answer. I hope all of you got it. I hope everyone got it. Yes, so option is perforation with only stapedial discontinuity. Then also it's fine because through the perforation, the sound waves can now go to the oval window. So whenever there is an alternate pathway via the perforation for sound waves to go to the inner ear, then the amount of hearing loss will not be as much as when it is with an intact tympanic membrane. I hope all of you got it. Okay, the next question, amongst the nerve injuries, which one has bad prognosis? So this is a question which is again a slightly tricky question, but I wouldn't say completely tricky question. So bilateral internal laryngeal nerve injury, unilateral internal laryngeal nerve injury, bilateral recurrent laryngeal nerve injury, or bilateral unilateral recurrent laryngeal nerve injury. What do you think is the answer? Which one will have bad prognosis? So first of all, let's cut two options. In unilateral RLN or unilateral internal laryngeal nerve palsy, no major deficit, no major problem is seen. So the prognosis of these two will definitely be good. So these two are out of the question now. Now the only two options that we can be confused is bilateral ILN versus bilateral RLN, right? Okay, so if they've asked you, Shravani, that which one is life-threatening, if they have asked you this question, life-threatening, now let us see. So basically, whenever there is an internal laryngeal nerve injury, we know internal laryngeal nerve is specifically sensory above the level of vocal cords, right? So it is sensory above the level of vocal cords. So if there is a nerve injury, what will happen? There will be loss of sensation. If there is a loss of sensation, can there be a risk of aspiration? Yes. Is this only what we are worried about because of internal laryngeal nerve injury? Yes. We are not worried about anything else other than aspiration when we are talking of ILN injury. Now, when we are talking of bilateral recurrent laryngeal nerve injury, what will happen? Vocal cords will come to midline position because RLN supplies the abductor of the vocal cord, which is posterior cricoarytenoid. So, when the vocal cords come to midline position, what is the problem here? The patient will have stridor. Now, which is life-threatening? Of course, aspiration can be life-threatening, but immediately which one is more life-threatening? Okay, so the options were only for RLN where they said partial or complete. Is this the question? What the language of the question was that? If it is that, I will explain that as well. But for now, we will just discuss between ILN and RLN. Yes. So if there is stridor, what will happen? Stridor is life-threatening. So now you definitely know that amongst ILN and RLN, the most life-threatening is stridor. So our answer, if this was the exact question, it would have been bilateral RLN. Now, even if they ask you unilateral or bilateral RLN palsy, which is partial or complete, your answer should be complete. Whenever there is a complete palsy, there is no chance of recovery. So of course, they're going to have bad prognosis and that can be more life-threatening. If it is partial injury, there is a possibility of recovery. There is a possibility that after a few months of steroid therapy, if the nerve is decompressed, the nerve can recover. So the answer will be bilateral complete RLN palsy. I hope everyone got it, and why? इंटरनल लैरेंजियल नर्व नहीं था ऑप्शन में, फाइन. सो अगर इंटरनल लैरेंजियल नर्व नहीं था तो आपको अब इजी है कि इट इज आरएलएन पैल्सी. यूनिलैटरल आरएलएन पैल्सी, वन कॉर्ड इन मिडलाइन पोजिशन, द अदर कॉर्ड इज मूविंग, सो नो प्रॉब्लम एट ऑल इन दैट सिचुएशन. वेदर इट इज कंप्लीट और पार्शियल, वी आर नॉट वरीड, सो दैट्स गॉन आउट ऑफ द क्वेश्चन. बाइलैटरल आरएलएन पैल्सी में स्ट्राइडर होगा, स्ट्राइडर होगा तो क्वेश्चन इज कंप्लीट में ज्यादा प्रोग्नोसिस बैड है या पार्शियल में? ऑफकोर्स कंप्लीट में, क्योंकि देयर इज नो चांस ऑफ रिकवरी. हो गया? ऑल ऑफ यू आर राइट? Got it? I hope you got it, Khushi. I thank you for giving the complete question. Now I get it. Everyone understood this? We shall reframe that question again. Okay. Croup is caused by streptococcus, caused by influenza, caused by H influenza. ये तो standard repeat है, हर time आता है. So I don't think we have to discuss this. Come on guys, answer this question very quickly. Croup is nothing but laryngotracheobronchitis. It is caused by which organism? So croup is caused by, it is caused by para-influenza virus, right? I think para-influenza was not there in the option. So what will you do? You will choose any of the other respiratory viruses, which is influenza. Streptococcus and H influenza are bacterial infections. They are not responsible for causing croup. They're responsible for causing epiglottitis. So what will your answer be? It was influenza. Last option was diphtheria. Okay, so we'll add this last option to complete your question, right? So I think we have recollected all the 8 questions. Or koi questions tha that you recollect, please let me know in the chat box if I have missed out on any questions. There were 8 questions in ENT. I think 6 were relatively simple, quite easy. 2 were a little tricky, but you could have analytically done it. These are not new topics, these are commonly done topics. So I think that was not very, very difficult. ENT mein to I think you should be able to get at least 6 plus out of 8. Yes? So if yes, all of you have done good in ENT, quickly give me a thumbs up in the chat box. That will help me know that all of you have really learned and done well in your ENT exams. Any other question? Thank you, Bhaskar, if you felt that my RR was useful. Okay, so ma'am, that coronal section cadaveric image, which cadaveric image? Atsmo, I'm not getting what you're asking me. What cadaveric image are you talking about? Okay, so I think if there's any more questions, feel free to post in the chat box. We'll come back and I will discuss this again with all of you. So thank you for all for joining in and giving me your inputs through the entire session. For now, just relax. If you're getting things, just take it as it comes, but don't overthink and don't get negative about what has happened. We still have NEET PG coming in, and stay positive, stay calm, and I will see you again later.